So thromboembolism in pregnancy, it's one of the very controversial topic and debatable topic, and it's a huge topic. I think it's 15 minutes is very small duration, a short duration to discuss about this, but I will make it short, discussing mainly about the risk factors in pregnancy regarding thromboembolism, and similarly we'll be discussing about the treatment protocols as well as diagnostic algorithms. So thromboembolism in pregnancy is one of the main leading cause of maternal mortality and morbidity next to bleeding. In terms of non-obstetric causes, causing maternal mortality, thromboembolism is one of the most important cause. Pregnancy and puerperium both are like hypercoagulable states, both can be a kind of thrombophilic states. And because of which the risk of venous thromboembolism in pregnancy is like 4 to 6 times more than the non-pregnant females. Mainly in terms of when we see postpartum, there is 57% more chances of venous thromboembolism. And when we see during peripartum, like during deliveries, normal deliveries compared to normal deliveries, elective cesarean sections and emergency C-sections, thromboembolism is high risk. And when compared to electives, emergency C-sections has a very higher risk. And the risk of thromboembolism in terms of trimesters, like first, second, third trimester is almost equal. But when compared to postpartum, the thromboembolism is lower in terms of all the trimesters. And when we see the pathophysiology of thromboembolism in pregnancy, why it occurs, what is the cause. Before discussing the thromboembolism, we'll discuss short about what is the physiology of hemostasis. Like when there is a vascular damage, we see initially vasoconstriction, followed by there will be a temporary platelet accumulation, forming a platelet plaque, and there will be a coagulation factor accumulation, which we see in terms of intrinsic pathway and extrinsic pathways. Through both these pathways, we'll be seeing activation of factor 10, followed by we see thrombin activation and causing fibrinogen converting into fibrin, and this causes a fibrous tissue where heals the tissue. But in terms of pathophysiology in pregnancy, where we see it is a hypercoagulable state, there is a virtuous triad in terms of there will be three things. There will be a venous stasis, there will be a hypercoagulability, and as well as there will be a increased vascular damage. Venous stasis in pregnancy is mainly because of gravid uterus compressing the vena cava, inferior vena cava. Similarly, when terms of when we see in pregnancy, venous stasis, there is a iliac arteries, right iliac artery compressing the left iliac vein, because of which DVTs are more common in the left leg when compared to right leg. And in terms of pregnancy, the hormonal changes which can cause influence in causing the venous dilatation, and immobility is very common in pregnancy, which can cause risk of venous stasis leading to thromboembolism. And pregnancy itself is a hypercoagulable state where we could see there are a lot of things happening in the pregnancies. There is an increased fibrinogen levels up to 50%. There will be increased coagulation factors like factor 5, 10, 9, similarly as well as 12. And in pregnancy, there will be a more of decreased fibrinolysis and protein C and S, out of which protein C activation is decreased, mainly because of plasminogen activator inhibitor 1 and 2 both activations. All this causing a hypercoagulable state, and in mainly during deliveries, like normal deliveries as well as C-sections, where you can see there is a endothelial damages or vascular damages and compression of the veins during normal deliveries. All these things significantly induce hypercoagulable state. But why hypercoagulable state in pregnancy? Why it is like so much risk? Why it should be necessary? Like hypercoagulable state in pregnancy is also advantages. Like during delivery, mainly during puerperium, where you could see that separation of the placenta, where hemostasis is definitely required. If hemostasis doesn't occur early, there will be a lot of blood loss, because of which there will be both maternal morbidity and mortality. So in terms of benefits, but there is also a lot of risk because of this hypercoagulable state. And when we see this risk factors, there are a lot of risk factors in pregnancy which can increase the chances of thromboembolism. And risk factors, when we discuss about risk factors are categorized into very high risk factors, and intermediate as well as low risk factors. This is one of the slides taken from RCOG guidelines, where you could see that mainly a patient having pre-existing conditions like venous thromboembolism. Venous thromboembolism, again, single episode of venous thromboembolism because of major surgeries, and venous thromboembolism be unprovoked or because of idiopathic reasons. If it is because of idiopathic reasons, that we categorize or score it as 4. If it is a single venous thromboembolism, that is because of major surgeries, we categorize as 3. And thrombophilias, there are 2 types of thrombophilias, like inherited thrombophilias as well as acquired. Inherited, we can see that protein C and S deficiency, factor V Leiden mutation, and heterozygous and homozygous, similarly as well as antithrombin 3 deficiency. And there will be some kind of other acquired thrombophilias like antiphospholipid antibody syndrome and hyperviscosity syndrome. This acquired thrombophilias with antiphospholipid antibody syndrome, we can categorize at grade as 3, whereas high-risk thrombophilias like antithrombin 3 deficiency as well as heterozygous homozygous factor V Leiden as well as heterozygous compound both protein C and S deficiency, we categorize as 3. Whereas other kind of factors like prothrombin gene mutation and homozygous factor protein C and S deficiency, we categorize as low risk thrombophilias which score as 1. The few patients initially have their medical predisposing conditions like heart diseases or lung diseases, heart failure, and having some kind of autoimmune diseases like inflammatory bowel disease, inflammatory polyarthritis, and type 1 diabetes with nephropathy, nephrotic syndromes, or blood-related disorders like sickle cell anemia. All this we can categorize as or grade them as 3 score. And based on the age, like age more than 35, based on the obesity is by BMI, like BMI more than 30, we grade it as 1, and BMI more than 40, we grade as 2. And parity, like more than 3, we grade as 1. Smokers as well as having varicose veins, gross varicose veins, we grade as 1. There are other obstetric risk factors where preeclampsia we grade as 1, and patient is on assisted reproductive techniques like IVF, we grade as 1. Patient has a multiple pregnancies, twin or triple pregnancy, we categorize 1. Patient in terms of C-sections like elective and emergency C-sections, emergency C-section we categorize 2, elective C-sections we categorize as 1. And there are prolonged labor more than 24 hours, PPH like more than 1 liter or required transfusions, preterm birth less than 37 weeks, and stillbirth in current pregnancy, we categorize as 1. Transient risk factors like in first trimester, there will be hyperemesis gravidarum, we categorize or grade it as 3, and hyperovulation, ovarian hyperstimulation syndrome, we grade as 4. Any surgical procedure undergone during the pregnancy as well as postpartum, like postpartum sterilization or appendectomy, cholecystectomy, we grade as 3. Immobility or prolonged travel like more than 4 hours, hospitalization using some intravenous antibiotics more than 3 days for conditions, different conditions like urinary tract infections or pyelonephritis or any kind of respiratory tract infections, we can grade them as 1.